for the CD program and workshop. As we gather here today, I am reminded of a powerful quote by Mahatma Gandhi. It says that, "Live as if you were to die tomorrow, learn as if you were to live forever." This quote beautifully encapsulates the spirit of our event, where we celebrate the pursuit of knowledge and endless possibilities it brings. Today's program is not just about expanding our knowledge, but it's an opportunity for all of us to connect, share insights and discuss the latest trends and advancements in the field of dentistry. To begin this wonderful day, let us invoke the divine blessing with the prayer song. Let us raise and join our hearts in the prayer.
Also, in case of complex root canal anatomy like calcified canal with aberrant root canal malformations, we also need guide. Dr.Sri Latha will enlighten us on the technology, the cutting edge technology what we have, guided endodontics, which has revolutionized the way we do the endodontics today. At the outset, I cherish the moments we spent 20 years ago where we were fortunate enough to be led by most eminent teachers and professors who are nationally as well as internationally acclaimed. I take this privilege to introduce our guest speaker for today, Dr. Sri Latha. She completed her BDS from PNM Dental College, Bagalkot, and went on to pursue MDS in Conservative Dentistry and Endodontics from Cambridge Institute of Dental Sciences, Belgium. She has done her Masters in Oral Lasers from Vienna, Austria. She is having more than 20 years of teaching experience. She is presently working as professor in M.A. Rangunwala College of Dental Sciences, Pune, and she is also a PhD scholar in guided endodontics. She has 41 publications to her credit in various national and international journals, including Journal of Endodontics. Hope all of us will have a memorable learning experience. Thank you.
I would like to invite our principal, Dr. Vijay V.K. sir, to come forward and present the token of appreciation for our honorable.
A very good morning. Actually, it's been a small, it's a brunch time, I think. It's not a morning, it's not a lunch. We are in the middle of the morning and afternoon. And actually, it's a much privilege and pleasure to welcome you all to today's series program on guided endodontics, which is conducted by our college, Airways Dental College and Hospital. And it's honor to serve as your host for this important and enriching event. I welcome the speaker, Professor Dr. Sri Latha, who is doing the extensive research on the guided endodontics, and all the delegates from and in and around of Coimbatore. And we are delighted to have you with us. And it's time to take up a step ahead and consider how your practice can evolve over the next few years. In this medical world, it's very important to always be in the know the new technologies, new treatments, and the new opportunities are always evolving in and around. So dentistry has advanced in leaps and bounds from its beginnings to the present day, and the future of the dental professionals is very bright here, and such technologies are the future of our recent dentistries. And technologies are on their way to become a regular part of the dental practices worldwide, and you can begin making the preparations and thinking of the ways to implement this to the new technologies into your practice, and to improve the quality of your patient's care also. And I congratulate on this regard the Department of Conservative Dentistry, head of the department, and the team, and the female postgraduates, and it's called as a female department, and which is headed by the male. So it's a very unknowingly or knowingly, the candidates who are joining in endo departments are always the females here. No other men's are here. So, but it's headed by the three men's, Dr. Sibi and Dr. Vinu sir and Dr. Vinay sir, and these females in these departments are very enthusiastic, because I used to always go to the departments. I have a conversation with them, the postgraduates, and so the guider who has come, as the video is showing, as it's not an older one, it's I think it's a younger one. So younger ma'am has came here to guide you as well. So thanks for coming, ma'am. Thanks for coming. And have a great day, and delegates who has come from the other departments and other colleges, thanks for coming, and you please have to wish to have a very good time and knowledge here in our platform and in our college. Thanks for coming.
Precision is a key to unlocking success. Measure twice, cut once. We are here today to enrich our knowledge and broaden our horizon through the insightful words of our esteemed guest speaker, Dr. Sri Latha ma'am. Let's make the most of this opportunity to learn, grow together. Over to you, ma'am.
So, until he starts the presentation, thank you so much for the kind words, Sir, Vijay sir, and Vinay. Vinay and me have, we've been together as postgraduates and after that even he stays in Bangalore, so we keep meeting and we keep updating each other what we work and what I am doing or what he is doing. And always when he speaks, he is very proud of this college and he is very proud of his department where he is working in and the team he has. And told him this, like when I come here, I would want to see how you all work together and have such a good team. So thanks for having me here, Vinay. And without, can I start? Scenarios which we come across, which portrays to us as a challenging situations. What do we do when we come across such a situation? So as we appreciate, the tooth 1 over here is calcified, and the same again in the second case, it is 1 which is calcified and discolored like this, and it appears on the radiograph like this. We are so happy and we are so satisfied, and we start the root canal treatment and we get the canal and we are fine. What if the canal is blocked? Now according to the literature, according to this IEJ by Bucharest et al., what it states is this kind of a scenario is quoted as a highly difficult case in our fraternity. Now it also says that though we are advanced with our microscopes, with the ultrasonic tips which we use, but still if suppose the root canal is calcified till the apical third, what happens over here is we ultimately end up jeopardizing the whole root canal dentin, and we might end up doing an apical surgery in such kind of scenarios. I hope you all agree with me. Yeah? So what about this case? This is a dense case, like as rightly Dr. Vinay was just mentioning, in varied root canal morphologies, this again presents to us as a big challenge. Now this, when we get into the detail of this in the literature, in our own publication, in the clinical oral investigation the last year, we conducted this prevalence study and we found that the type 2 dents is the most commonly seen. Maybe it is not so statistically significant, but still it makes or marks an impact in how we see it. So when we conducted the study, according to the among the 19,000 teeth we screened, we found that almost 77 teeth were affected with dents, among which almost 55 teeth were the lateral incisors. So we cannot neglect such kind of varied root canal anatomies, and we as clinicians, we need to be prepared when we come across such situations. Now, what about this situation? What do we see over here? We see resorption. When we come across such situation, we are confused, we are baffled, we think whether we are supposed to refer this case to an experienced endodontist or a surgeon, or we treat it orthograde, or we treat it retrograde, and we are ultimately confused. Now what about this? In such a situation where the patient has undergone a root canal treatment, the tooth is being retreated once, but still the patient complains that he or she is still symptomatic. Then what do? We are confused. Like if suppose I take up this case for an endodontic microsurgery, what would happen? What if the bleeding gets worse? Or is this incision right or wrong? Or should I switch to a different approach? As clinicians, all these thoughts waver around our mind. Now what about this case? There is a severely malpositioned tooth in which taking an axis and getting a straight line access to the root canal would be a huge challenge for us. Now, just imagine there is a storm and there is a sailor who's trying to cross the sea, and he's still using the old maps and the sextants over here and trying to cross the sea. But imagine if he is equipped with the GPS. Now, in the same way for us as dentists, as this guided endodontics acts as a GPS. So now, my topic for today is precision in practice and the clinical and the scientific perspectives which contribute to this. I will be discussing this in detail. So now let us look into static endodontics. Now what happens in static dynamic guided endodontics is, now the patient comes to you, then you expose the patient to a CBCT scan. After you expose the patient to the CBCT scan, along with that you also take a digital scan. So this can either be a digital scan or it can be an impression. Earlier what we would do is we would take an impression, pour a cast and then send it to the lab. But now since we have advanced more in this field, digital scan is more preferred. After you do this, so these are the two prerequisites we need to have when we send it to the lab. After this, what happens is, we go into the planning part. This we need to coordinate with the lab and we get the planning done. So at this step, they use a software. This is one of the software which they use. Here, initially what is being done is, both the coordinates are matched. Like the CBCT and the digital scan are merged. So for this, as we see here, you can see these red marks. You choose different coordinates between the digital scan and the CBCT and both are merged. Once it is merged, then can you all appreciate this axle over here, this green axle? Sometimes what happens is, if you see here, this is a section which will give us an idea whether the CBCT and the digital scan is merged well. If suppose it is not merged well, we need to manually merge them. So that is when you mark these coordinates, and this axle, it rotates 360 degrees and it merges both the CBCT and the digital scan. Then after that, this is how it is seen. You can have all the different views, the axial view, the tangential view and the sagittal view. So after this, your next step, what the technician does is he selects the implant. Now what I would like to mention over here is, this came into a picture in dentistry in the field of implantology. So that is the reason in this software, when you are working with it, you would only find an option to select an implant. So this, as an endodontist, it directly implicates to the drill which we are going to select. So when you select the implant, this is how it looks. Okay, the coordinate, it is again the axle moves 360 degrees and you align it properly and check the alignment in all the ways, in the axial section, in the sagittal section and the tangential section, and when you are satisfied with the alignment, then you give an instruction to go ahead. And this is how a virtual drill looks like. Now, this is I enlarged the picture over here. What you can see over here, this is the drill part. Now, these two rectangular boxes which you can see over here is the sleeve. Okay, so you go through this sleeve. This sleeve acts as a guide for us how you need to place the drill which we choose. So this is how it looks once it is planned. So here you can see in the 3D constructed view, this is the tangential view, this is the axial view and this is the sagittal view. Okay, now this is the case, this is one of the preliminary cases which we treated in the department when I initially started working on guided. Now this boy, he came to us because he was referred from the orthodontic department. He was actually came in for the orthodontic treatment and he was referred to restore the 1-1. But when we went into the details, we got to know that he had a history of trauma and the tooth was calcified. And we scheduled this for a guided case, and this is a small video. Now whatever I spoke about is in the form of a video which you can appreciate. Here the technician is importing the cast over here. This is the initial cases since I was, so that time we used to take an impression, pour a cast and send it to the lab. So that's why there is a cast over here. So see how the technician is choosing, or is trying to merge both the CBCT and the cast by marking these coordinates. Okay, so once it is marked and once it is merged, then what he is doing here is he is selecting the drill. After he selects the drill, this is how he places it and checks the alignment in all the directions. Okay, so once he does this, then what happens is he is making the stent. So while making the stent, the areas of undercut is blocked, and this he marks the outline of the stent, and this is how it is being fabricated. Now the virtual stent is ready. This is how it looks like. Then the command is given to the 3D printing machine and the stent is ready. Now this is how it is being sent by the lab to us. These was the drills which I used. Now this is the after rubber dam isolation and the stent in place. This is the drill in place and this is the axis. So the axis over here, if you all observe, it is labially placed. So what happens in this particular case, in such scenarios, is you don't have to take that traditional axis which we take from the singular, keep it 45 degrees, then make it straight, and no, you don't have to do that. By using this because you have a CBCT which is already a 3-dimensional view, and you merge the digital scan, so you get an idea from where you need to take the axis, so you hit the canal straight. Okay, so that is what we have done over here. This is the top, this is the working length, this is giving calcium hydroxide, and the master cone and the obturation. So we can see over here how conservative or minimally invasive the access cavity is. Now this is the pre-op CBCT and this is the post-op CBCT. Now this is the 2 years follow-up, and this patient is doing well, and we can see how well everything is healed and the patient is undergoing orthodontic treatment now. Now this is another case. This patient came to us just with the complaint of his discoloration and nothing else. He didn't want anything else. He was totally asymptomatic. But again, when we went deep into the history, what we found was this patient also had a calcified tooth. He had a history of trauma which was 6 years back. Again, we took this case up for guided. Now this is the plan which was given by the lab. The guide in place, the drill, this is the axis. Now when you see the first case and the second case, we can see the difference in where we are taking the axis. So what I want you all to know is, so depending on each teeth, whichever you want to treat, you get to know where you are supposed to take the axis point, and the guide acts as a pathway for you. You know where to place the drill and how your axis finally comes out. Now this is the working length. The obturation. So this patient, we later on corrected the discoloration for him. He underwent an intracoronal bleaching. This is the crown prep. It was temporized. Later on, we gave the crown to him, all ceramic, and this is the post-op picture. Now this is the pre-op CBCT. We can compare the pre-op CBCT and the post-op CBCT over here. Now this is a 2.5 years follow-up of this case. Again, this patient is doing well, and there is we can appreciate that the tooth has healed well over here. Now when you compare this, this is the traditional axis when you see over here. Now look at this axis and look at this axis, okay, and also look at this axis. What we can see is there is, contrary to this traditional axis, especially near the pericervical dentin, you see the amount of dentin lost over here, and when you compare this with this, you can see how much of root canal dentin is preserved over here. And also, when you look at it in the CBCT, in the different views, this is a tangential view, and if you look at this axial view, if you compare the tooth which is not prepared and the tooth which is prepared, it is very, very centric, and also we have not compromised on the root canal dentin around. Now, this was another case where a patient presented with a huge lesion. In this case, only the lateral incisor was calcified. The central and the lateral were treated in a routine way. The plan from the lab. This is the stent, tooth after isolation. This is the lesion. Now, the obturation. Now if you see over here, see this lesion over here, this is after 6 months and this is after 1.5 years. We can really appreciate the amount of reduction in the periapical lesion by doing nothing, by just treating in an orthograde way and doing the necessary cleaning and disinfection procedures. And only thing is, as we saw the lateral incisor was calcified, we just used the guided for that. Now this is the, Now, a very root canal anatomy case with the static guide. Now this patient, this is how he presented to us in the Department of Conservative Dentistry and Endodontics. Now again, we took it up for a guide. Now this is the plan which we are making in coordination with the lab. So you can see over here, this is what I was telling. With the axle, the tooth, you can rotate it in all the 360 degrees and you can see how the canal is over here. There are two canals.
Yes. Can we, instead of that, can we use piezo remus?
Again, piezo, you will have the same challenge. Dense case, if it is a malposition case, whatever, and any other case where the tooth is not calcified. In such situation, if the burr reaches till the CEJ, till the pulpal, pulp, it is more than enough for you. But otherwise, the length of the drill will be a big challenge. I faced that challenge. That's why I was working on it, and we have tried to design a drill. Let's see.
Last question.
Yes.
You said without the sleeve we can, there are chances that we perforate.
Yes.
But also there are chances that we reach the canal.
Yes, yes. The chances for you, even if you don't perforate, you might not perforate also. Like I did that case without the sleeve. The first case, I did perforate. I did negotiate the canal, right? But I don't know whether you remember that radiograph, that deviation was a little more. That was because the sleeve was not there to give that exact apt bullseye location for me to get and reach the canal. That will be a problem.
To insert the drill for access opening.
Yes.
After access opening, we don't need drill.
We don't need, right? Afterwards the procedure is same.
Same.
There, what is our challenge? To locate the canal. Now suppose if that stent in the right direction, every 5 minutes maybe, and imagine the time which we require. By the time you locate that calcified canal, it will be at least, it depends on where the calcification is. It can range from half an hour to even 1 hour. Yes, but that is eased out for you, right? You hit the canal within, sometimes within few seconds also. If you are, if the plan is correct, if the drill is in the right direction, you just locate it. You will locate the canal. We can do it. It's more easier for us to do with the dynamic navigation rather than with the static. With static also we have done, but only problem is that mouth opening and that you need to place the stent also. Then afterwards you need to take that again the height of the aerotor, that again the drill, again you understood. So that is a challenge with the posterior teeth, but this will be omitted with the dynamic.
Any other questions?
Fit of the guide.
Pardon?
How to check the fit of the guide?
Fit of the
Is there any
guide.
consideration?
Yes, definitely. It's a good question. What we do is, once the guide comes to us, the first thing we do is we schedule an appointment with the patient only to check the fit of the guide. Okay? So when you when the guide comes to you, when you place it on the patient's mouth, you will get to know. You know like when you do the denture or something, when you place it in the patient's mouth, you will get to know, right, whether it is fitting well, or then you know the angulation, when you can even place the drill and check. Okay.
So one thing is that the sleeve what we are using. Okay. So what is the effective diameter you tell us? You could tell us what is the diameter?
Volume of the pulp.
Okay.
Or is maxillary anterior.
Okay.
It is seen of the head diameter of the months which is available, or the messenger, or maximum 0.008 is the maximum head diameter we can use to get a nice and a good preparation in the canal. Because the volume of the pulp is not more, you cannot make it more than that.
Okay. Fine. Do we have the sleeve accordingly? That's my question.
That's what we have to manufacture.
Still it is not there.
Scenario. That's
Okay.
the biggest challenge.
So what is the percentage of error we can expect with these kind of sleeves and the bursts what we have nowadays? In a clinical scenario speaking. Right now, since we don't have anything, we have to do. That we can't escape. So what is the error percentage? Does it have?
Actually, I can't tell with the exact number and statistical analysis. This is the percentage of error. If you would have seen in the cases which I have treated, 2 cases have gone wrong. I have gone wrong in that alignment. I have created.
No, not the alignment. The sleeve and the burr. If you use conveniently.
It is because of that only, no?
It's an offset I think which was wrong, like the angulation.
The plan which was given, only the accuracy was not correct.
Okay, the plan itself.
So that accuracy does matter. It's still we cannot, once the plan is come and it is completely compatible, we can't say like that. It still has, I have gone wrong. Twice I have gone.
Okay. So according to what I understand by that, we have an effective diameters of both to be successful. Is it right?
We need to.
And one thing. The second part is the offset, what we give in the stent, right? So that depends upon the angulation, whatever angulation you want to enter. So that becomes more crucial than the diameter, or both has the equal.
Will play a role.
All the 3 axes what
Yes.
we are speaking about.
Yes. Yes.
Thank
Like
you.
that thing, if we put an offset, now we know till where the calcification is. So the offset will, let the burr go only till that particular length.
Okay.
Now we suppose even we make the drill to whatever length, but it will stop us till where.
Okay, not the length, the diameter wise I am speaking about.
Diameter is, that's it. That is what I told you about the
Okay.
diameter.
Okay.
Now we need to, it can, maximum I think we need to prepare till 0.008, not more than that.
Not more than that. Okay. Thank you.
Yeah. Dynamic, the 2 challenges are, one is the cost, which the clinician has to invest, it is around 50 lakhs. And the second thing is the learning curve. But the good thing is, the support team is there. Like, one thing about the dynamic navigation I would like to mention is, now suppose, whatever cases we are doing, it is being recorded, and it is being recorded in, even in the headquarters, that case is saved. You got it? Suppose the headquarters of that navigator is Canada, the person in Canada also can access that case from there and correct it and can guide me. You got it? So that is one good thing about dynamic navigation. And each license, there is something called as license. We need to buy licenses. First time when we buy the machine, some 25 licenses are given to us. Okay, after that you need to purchase. So each license costs around 4,500 or something. So when we are charging the patient, we need to charge all these things in it. Now even if for the static guide, even then you will have to charge for these stents. That is also around I think 2,500. Again the digital scan, the CBCT and everything. Now around whatever patients come to the department, I tell them before only you need to spare around 4,500 rupees. And then we go.
When we use the second stage
Yes.
for surgery,
Yes.
is it possible to keep it along with standard surgical aseptic techniques?
I will get it.
How can we sterilize it when we go forward? When it comes from 3D printer
Yes.
and we use it for surgeries,
Then we can only do cold sterilizations.
Cold
The static guide you're telling us,
Yes, ma'am.
we can only cold sterilize.
the material
But
is done.
yes, yes. Cold sterilization it does with steps.
Solution protocol to be much better when we use for more
That is also a
invasive
good point. We can,
procedures.
yes. But we can now, at present, we are only cold sterilizing this.
Yes, we can do, but in
Yes.
India we follow this.
Yes.
But if we publish or take it to European
Yes.
standard, they will expect
Yes.
sterile at the point of use.
Yes.
For this guide to be automated.
Yeah.
And what are guides I personally use for implants? They are made from Korean companies only.
Okay.
And again, they recommend to do a cold sterilization. Basically, what I do is I dip in hypo, then wash with saline, and use it. Hopefully, hypochlorite should kill each and every particles is available. Otherwise, one more option is available. We can use UVC. UVC specifically. We can leave it in the cabinet. Then we can wash it. The guide sterilization protocol. They are not recommending to do any order. Otherwise, one option would be gamma radiation. Gamma radiation again is not possible. Ideally, in a clinical scenario, either we can manage it hypo. Hypo you have right, nothing is happening. There is no deformation or softening of metal, nothing is happening. Hypochlorite, wash with saline, you are able to do it. UVC you have tried. Disadvantage would be the word is otherwise, UVC is a very excellent method to do it.
Examination hall.
Every angulation you should, that drill ka path should match. In every angulation it should go. Now this is, that there it was the we have done is we have used the adapter since it has to go into this. So we get a little 3 more extra because of that. And this diameter is 0.0. Just pull it. Don't from there and don't play with the change it like this. So when you place it, see, you feel whether you know you are getting the some common sense, whether it is the inside or the edge or not. Got it in that, let's open and check. நம்ம பேசி சொல்லுமே.
Good evening. Today with the new ideas, knowledge to apply in your practice, patient care. Let's continue our pursuit of excellence in dentistry. Now I would like to call our principal sir or head of the department to felicitate our guest speaker Sri Latha ma'am. Gayatri, Mohammed, Shika, Monisha, we would like to call Dr. Sri Latha ma'am to give the next certificates. Shika N. Sharma, Monisha R. Raga Vinodini, Renuka S. Dr. Meena, Gayatri, Dr. Shweta, Dr. Malay Kersi, Dr. Surinder, Dr. Anita T. Good evening everyone. It's my privilege and honor to deliver the oath of thanks for this wonderful series. Gratitude to our esteemed director and principal, Dr. Vijay sir, for his unwavering support and encouragement in organizing such enriching programs. Sir, your visionary leadership and commitment to excellence, coupled with approachable and empathetic nature, inspires and motivates us to achieve more and strive for the best. Thank you, sir. I extend my sincerest thanks to our distinguished guest speaker, Dr. Sri Latha ma'am, for sharing profound insights on guided endodontics. Ma'am, your enlightened presentation and the subsequent hands-on session have undoubtedly broadened our horizon and enriched our understanding. Your generosity in sharing your expertise with us today. Thank you, ma'am. We are grateful to our department for his constant support and guidance. Sir, have been pivotal in ensuring the success of today's program. Thank you, sir. My sincerest thanks to our professor, Dr. Vinu, sir, for relentless support and guidance. Thank you, sir. To the head of the department and faculties of other departments who have graced us with their presence this morning, I extend a warm thank you. A sincerest thanks to our administrative officer, Mr. Rajgopala, sir, for study support and timely guidance. Heartfelt thanks to the postgraduate delegates from Sri Ramakrishna Dental College, KSR Dental College and Vivekananda Dental College who have joined us today. Your presence have added great value to our program and we hope you found it to be a worthwhile experience. Thank you. Special thanks to our system analyst, Mr. Naveen, for taking care of audio and visual aids. I must also acknowledge the dedication of our faculty members. I must also acknowledge the dedication of our faculty members, Dr. Siddhi sir, Dr. Surya ma'am, Dr. Abhinaya ma'am, Dr. Devipriya ma'am and Dr. Sneha ma'am, whose hard work and enthusiasm have been vital to this event's seamless execution. Special note of thanks to our non-teaching staffs, Sasi sister, mother sister, Mrs. Muthulakshmi and Mrs. Rani, whose behind-the-scenes contribution have ensured smooth running of today's program. My deepest heartfelt thanks to our dear postgraduates who have wholeheartedly dedicated themselves and worked tirelessly over the past couple of days. Thank you, dear PGs. Dear interns, we are truly grateful to all of you for taking care of the intricate work with complete dedication and grace. Thank you, dear interns. Finally, to everyone here, I offer my sincerest thanks for your presence and support. It's your collective contribution that had made this event truly memorable. Thank you all once again, and I hope we continue to learn, grow and excel together in our shared journey towards advancing the field of dentistry. Wishing all a pleasant evening ahead. Thank you.